Welcome, ladies and gentlemen, to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon, and if you're watching this video, you or a loved one has recently been diagnosed with a brain tumor. Now, first, I want to say that I know this can be overwhelming, and it can create feelings of fear, confusion, denial, and a lot of questions. So the purpose of this video is not to get too deep into the weeds about brain tumors because that is a huge topic. But we're going to talk about the basics, what a brain tumor is, how it's diagnosed, what are the treatment options, what kind of questions might you want to ask your care team, as well as a little bit about brain tumor categories in general and what that might mean for prognosis. We'll talk a little bit about superficially what surgery for a brain tumor might involve and what that'll be like. Follow through with us for this entire video, and we will give you the basics about brain tumors. So when we first talk about brain tumors, we need to kind of think about them in certain types of categories. And the two big categories that you want to think about when it comes to brain tumors is, number one, is the tumor a primary brain tumor or a metastatic brain tumor? And then number two, is the tumor malignant or is it benign? So if we talk about primary versus metastatic, a primary brain tumor comes from cells in and around the brain itself, as opposed to spreading to the brain or around the brain from other parts of the body. And this is going to be an important distinction on how you treat these tumors. The other category is it benign or malignant? Now, a benign brain tumor may sound less nasty than a malignant brain tumor, but remember, because a benign tumor is benign, it can grow very slowly and therefore get very large before it causes symptoms. In addition, benign brain tumors may not be as susceptible to treatment for brain tumors because a lot of brain tumor treatments rely on the fact that the cells of the brain tumor are dividing quickly. And in a benign tumor, that may not be happening. A malignant tumor is a more aggressive tumor and is often not going to grow as slowly as a benign tumor. And therefore, a malignant tumor can be very small but cause a lot of trouble because it's growing fast. We'll get into a little more detail about the specifics of those categories, but it's important to remember that the brain tumor can either be primary, coming from the tissue in the brain itself, or malignant, coming from other places like the lungs, the kidneys, the skin, the prostate, the breast, those kinds of cancers that spread from other parts of the body to the brain. And then if you do have a brain tumor, whether it's primary or metastatic, the question then to ask is it benign or malignant? Another issue to think about with respect to brain tumors is where is the brain tumor located? Remember, the brain is trapped inside the skull, and the amount of pressure that's occurring inside the skull because of the brain and the other tissues inside the skull is highly dependent on the volume of those tissues. You're going to have cerebrospinal fluid, brain tissue, and blood. If any one of those compartments has something in it that's not supposed to be there, and the volume of that compartment increases, the pressure has no choice but to increase because the tissues are trapped inside the skull. And this is basic, physics regarding volumes and pressures. But the kicker is that if you have a brain tumor that's taking up a lot of space, or a brain tumor that's not taking up a lot of space but causing a lot of swelling, the location that tumor is in is going to be very important. For example, if the location is near an area of the brain that can cause seizures, you may have seizure symptoms. If it's in a location in the brain that could be blocking the flow of spinal fluid, it can cause an increase in fluid pressure and headaches, nausea, vomiting, confusion, decreased level of consciousness. If it's near a part of the brain that deals with speech or movement, that may affect your treatment options because you can't necessarily do an aggressive surgery in those areas because it could lead to neurological deficits. In addition, keep in mind, if we're dealing with a malignant type tumor and you see a picture of the tumor on an MRI, for example, of the brain, even though what you're looking at looks like, oh, that's the entire tumor, keep in mind there may be microscopic tumor cells outside of what you see on the picture that won't show up on an MRI because the MRI looks at larger structures. So if you have a malignant brain tumor and you see a round ball on the MRI in a particular spot, the chances are high that malignant brain tumor cells are outside of that area that you just can't see. So location will have a lot to do with symptoms, including both pressure symptoms as well as neurological symptoms. So what kind of symptoms can brain tumors cause? Well, the first sort of category of symptoms is those dealing with pressure. So if you have a buildup of pressure in your brain from a brain tumor, either from swelling from that brain tumor, the brain tumor itself, or blockage of fluid causing a buildup of spinal fluid pressure, the first symptom you're going to have typically is headache. These headaches can be worse in the mornings or when you're lying down. They can be associated with nausea and vomiting. And if that pressure increases severely enough, you can get changes in levels of consciousness. So that would mean alertness and wakefulness. The other symptoms that occur with brain tumors are typically associated with their location. So as I mentioned before, if the brain tumor is near the speech center, you might have trouble speaking or understanding speech. If it's near the part of the brain that controls movement of the face, arm, or leg, you might have paralysis or weakness in those parts of the body. If it is near parts of the brain that control vision or balance, you may have changes in those type of abilities because of where the tumor is located. And then finally, especially large parts of the front of the brain, you can get changes in cognition, memory, attention, concentration, personality traits. All of these may be affected by direct injury of the brain tumor cells, injuring normal brain tissue, or swelling from the brain tumor bothering or injuring normal brain tissue. So symptoms are related to pressure issues and location issues. So let's talk a little bit about diagnosis. There are many kind of pathways that a patient can end up with a diagnosis of a brain tumor, but certain common situations that I would see are a patient comes into the ER or their doctor's office with a persistent headache that's not getting better, maybe associated nausea or vomiting, maybe neurological symptoms, and the primary care doctor or emergency doctor will order a CAT scan. Now, a CAT scan is a good, quick imaging modality that'll show abnormalities in the brain, and if there is a brain tumor in the brain, the CAT scan will certainly likely pick it up. And that'll either pick up the brain tumor itself or the swelling around it. Usually the information from a CAT scan is relatively limited on how much information you can get from that, get about the brain tumor. So the next test, if a brain tumor is found on a CAT scan, is usually an MRI with and without contrast. Contrast is a chemical that's injected in your vein, and it will light up tissues in the brain that are exposed to the bloodstream. Oftentimes in brain tumors, the barrier between the peripheral or outside blood system and the system inside the brain is broken down. And brain tumors will often recruit blood vessels to supply them that don't have the normal barriers in them that other blood vessels in the brain do. And that dye that is injected into your vein will light up on the MRI scan in an area of a brain tumor. And we know what areas should light up and should not. So if we see a big, bright, round ball in a part of the brain that we know shouldn't have that, we can diagnose a brain tumor. The quality or characteristics of an MRI scan can also show characteristics of a brain tumor that can give some hints as to what it might be or what type it might be. Both benign versus malignant, both metastatic versus primary. There are little hints that can be seen on the MRI scan that are known for particular types of tumors. And we'll take a look at some pictures of those in a little while. So once you have the MRI, you might be able to have a pretty strong guess of what kind of tumor it is, but the truth is that you do not really know what type of tumor this is without a biopsy. So another method or part of the diagnostic strategy for brain tumors is getting a piece of that brain tumor and then looking at it under the microscope and testing it with various stains and genetic tests. So the definitive answer on what kind of tumor this is, which is really what's needed for what kind of treatment you're going to get, is dependent on the results of the biopsy. There are often, and oftentimes, the other physicians that are going to be treating you for a brain tumor with things like chemotherapy or radiation or immunotherapy, they often are not willing to start those treatments without a actual tissue diagnosis, meaning a diagnosis from a biopsy. And that's because they don't want to take the chance that they're giving you the wrong treatment for a tumor that they think it is, but it's really not. So the biopsy that's taken could be one of two types, either a stereotactic needle biopsy or a biopsy that's done during an open brain surgery for removing as much of the tumor as safely possible. Now, a stereotactic needle biopsy is a less invasive procedure where a very small hole is drilled through the skull and a needle is guided into the location of the tumor using a computer navigation system and MRIs, and basically getting a tiny piece of that tumor with the needle without opening the skull with a large craniotomy surgery or manipulating the brain. Although lower risk than a large brain surgery to remove a large tumor, a needle biopsy is not without risk. The main risk, of course, is bleeding. You're basically putting a needle into the brain tissue in an area of tumor that is already known to not be normal with respect to vasculature. And that bleeding could be a little dot of blood that you see on a CAT scan after the needle biopsy that you never notice, to a massive hemorrhage that could kill you. So just keep that in mind regarding needle biopsies. They sound much less invasive, and technically they are, but they are not without risk. The other method of biopsy is to actually get a piece of that tumor during an open surgery, and that would be a larger surgery where a larger piece of bone is removed and an attempt is made to take out as much of that tumor as is safely possible. Now, safely is important here because a lot of it depends on how close that tumor is to important parts of the brain. So the key is to remove as much tumor as possible without hurting functioning or important parts of the brain. And typically what will happen is in the beginning of the surgery, a piece of that tumor will be sent to the pathologist, and the pathologist, while the surgeon continues working, is going to give a preliminary diagnosis, which is much more accurate than just looking at an MRI, but not as accurate as another couple of days of staining and immunochemistry to confirm the tumor. But enough information can be gotten from what's called a frozen section biopsy at the time of the surgery that can give the surgeon information to tell them, hey, how aggressive should I be? If this is a benign tumor that likely has a nice sharp edge to it, then I should be pretty aggressive and try and take that out because there's a chance of potentially curing this patient. If the frozen pathology comes back right away and says, oh, this is a malignant brain tumor, then you know that no matter how much of that tumor you take out that you can see during the surgery, you're never going to get all of it. There's going to be tumor cells that are in parts of the brain that look normal on the MRI and look normal visually to you as the surgeon. So if the pathology comes back after the first half hour of the surgery that this is a highly malignant brain tumor, chances are your surgeon will not be as aggressive in taking out that tumor because he doesn't want to get into parts of the brain that could be normal or functioning properly. So those are some basic ideas about diagnosis of a brain tumor. Now, once the surgery is done for the biopsy, whether it's the needle biopsy or the larger open biopsy, other testing can be done regarding the molecular characteristics of the brain tumor. In modern contemporary neurosurgical times, the specific genetic and immunohistochemical aspects of brain tumors are now very, very important for treatment options, because many of the treatment options target these qualities of brain tumors that some tumors have and some tumors don't. So if you have a brain tumor and it gets genetically tested for particular structures on the tumor cells, and let's say it has or doesn't have some of these structures, that may make you a better candidate for certain types of treatment. And we'll talk a little bit more about that later in the video. So those are the main kind of points, basic points about diagnosis of brain tumors. So what are some of the treatment options for brain tumors? Well, the first, which is one of the reasons I'm making this video, is surgery. And again, the purpose of surgery can be simply to do a needle biopsy to get a diagnosis of what kind of tumor it is, or it may be to debulk or decrease the size of the tumor so that it's more susceptible to later treatments. Or it could be to actually literally cure the problem by removing the tumor in its entirety. Curing tumors and removing them in their entirety are more likely with benign brain tumors. The classic benign brain tumor that is amenable to that kind of treatment is something called a meningioma. Now granted, there are rare grades of meningiomas that can be malignant, but the majority of meningiomas are benign. And these tumors can get very big because they grow slowly. But if the tumor is in a safe location, it's very possible to remove this tumor in its entirety, and the patient technically can be cured. Also keep in mind, when it comes to meningiomas, it's quite possible to have a meningioma your whole life and never know it. And it's not necessarily uncommon. For example, if you did 100 autopsies on 100 people who died of natural causes, probably 10 to 15 of them may have small meningiomas growing on the surfaces of their brain. Meningiomas come from the lining of the brain as opposed to the brain tissue itself. The lining of the brain is called the meninges, and that's where the word meningioma comes from. Meningiomas are very amenable to be removed. But also because of how encapsulated they are and how they grow, they're also very susceptible to something called stereotactic radiosurgery, which is another type of treatment, which we'll get into in a minute. So there's no way to really do a video on what the right answer is. There's so many variables involved in brain tumors and treatments that all I would say is that if you do have a meningioma, have a long talk with your neurosurgeon about what treatment options are ideal for that tumor based on where it's located and what it looks like on the MRI. Other forms of treatment other than surgery include radiation. That radiation can be different types. It can be stereotactic radiosurgery, which are many beams of radiation that are passed through the brain. And each beam by itself does relatively little harm, but where the beams meet, it can deliver energy to tissues, and that delivery of energy can be tailored to shapes and sizes of tumors and where they're located. And you can deliver very high energy to very focal points in the brain and literally destroy tumor tissue with that radiation. There's also something called whole brain radiation, where the entire brain is radiated with boosts to certain areas. And that might be, for example, more appropriate for a malignant brain tumor that has a big ball of tumor in one location, but you know that there are little tendrils of tumors pushing out from that center area into other parts of the brain. You also would likely know that if it's a malignant brain tumor, microscopic tumor cells are located maybe even on the opposite side of the brain because of this brain tumor. And whole brain radiation therapy would be aimed at addressing that. And then finally, there are more systemic type of treatments like chemotherapy. Chemotherapy literally is basically a poison for rapidly dividing cells. So tumor cells rapidly divide. So this chemotherapy treatment typically targets DNA replication or parts of that process. So if your tumor cells are dividing more than a normal cell should be, chemotherapy can selectively kill those tumor cells. But that's also why chemotherapy can cause hair loss and nausea and vomiting. That's because the hair cells are dividing and the lining of the intestines are dividing, so the chemotherapy will accidentally target those tissues also. There are certain chemotherapies that have been determined through clinical trials are better for certain types of brain tumors. So you would be working with your oncologist on figuring out, based on the biopsy results, what chemotherapy might be the best, or what we call standard of care for that particular type of tumor. And then finally, there are therapies called immunotherapies. These are relatively new from a timeline perspective on treating brain tumors. And these basically target markers that are on the surface of these tumor cells that are special to the tumor cells. So all the other cells in your body don't have a particular protein on the surface of their cell, but all of your tumor cells do. And if that's the case, you could create an immunotherapy that's basically injected through your vein, and it travels to every cell in your body, but only kills the cells that have that particular protein that immunotherapy links to. And that is a way to target just the tumor cells. There are other hurdles to overcome, like getting that medicine through the special barriers that your blood vessels have in your brain. But that is not an insurmountable problem. So immunotherapy is kind of the cutting-edge therapy, targeted therapy for brain tumors. And then finally, treatments that have really nothing to do with the tumor itself, but the effects or side effects of the tumors. And those medications are typically for the symptoms of headache, nausea, vomiting, effects from swelling. And the number one medicine for that are steroids. Usually that's a medicine called dexamethasone. And it is incredible how well steroids can decrease swelling in the brain from tumors. A patient could be terribly sick from the effects of pressure in the brain with headaches, nausea, and vomiting. They get 1 or 2 doses of steroids and the symptoms disappear. That's wonderful, and steroids are a mainstay of treatment for patients with brain tumors. But I will tell you that staying on steroids chronically or for long periods of time definitely has side effects, and it's unlikely that people can remain on steroids forever or indefinitely without significant side effects. But those are the top 5 or 6 treatments of brain tumors and their side effects. So now let's talk about some categories of tumors specifically, as opposed to benign versus malignant, primary versus metastatic. So for example, one of the most fearful or common tumors of the brain tumors are what's called the gliomas. And these tumors arise from a type of cell in the brain called the glial cells, which are actually not the neurons or nerve cells. They are the supporting cells of the brain itself. And they make up the majority of the cells in the brain. The grades or level of malignancy of gliomas range from grade 2 to grade 4. Grade 2 is relatively slower growing. Grade 4 is faster growing. Because of the mutation rates of gliomas, it's really thought that grade 2 is just a typical glioma that was found early, and that all low-grade gliomas eventually become high-grade. Treatment for gliomas include surgery, radiation, and chemotherapy. And important things to remember about gliomas, especially in more modern times, is that molecular markers on these tumor cells are very important in determining prognosis. And these are things like whether the cells have what's called an IDH mutation or a 1p19q molecular marker, as well as its methylation status. These things probably don't mean much right now on a basic general video, but if you're eventually sitting down and talking with your oncologist or neurosurgeon after the diagnosis of a brain tumor that's a glioma, you're going to be recognizing these terms. So gliomas are not a good tumor to have. In the population over the age of 45 or 50, if you are diagnosed with a glioma brain tumor, it's typically going to be a grade 4 glioma, which is otherwise known as a GBM, or glioblastoma multiforme brain tumor. And these are what are known as the most malignant brain tumors that exist. They are not good tumors to have. We are still not where we want to be in treating these tumors. Typical life expectancy after being diagnosed with a GBM is 1 to 2 years. So that is a very bad brain tumor to have. So that's gliomas. The other type of malignant brain tumors that are next most common are metastatic tumors. And these are tumors from other parts of the body. The most common origin locations for these tumors are the lungs, and in women, breast cancer. There are other tumors that can spread to the brain, including tumors of the kidney, tumors of the prostate, tumors of the skin like melanoma. They all can eventually go to the brain. Regarding treatment of these tumors, a lot of that depends on how bad is the metastatic disease in the rest of the body. If a patient has a known lung cancer and they were diagnosed a year ago, they've been getting treatment, they start getting headaches, and now we see a tumor in their brain, we can, statistically speaking, be pretty sure it's going to be a metastatic lung cancer in the brain. If it turns out that that lung cancer is also in the liver or has spread to multiple lymph nodes, the chances of the patient not making it because of the brain tumor are lower than the chances of them not making it because of the other parts of the body that have lung cancer. And in that case, for example, it might be decided not to operate on the brain tumor and thus just treat that with other treatments. So metastatic tumors are the second most common malignant tumor I would see in the patient population that I would usually see. And then let's switch over to other types of tumors, like the benign tumors, like the meningiomas. We mentioned that that comes from the meninges, which are the lining of the brain. Those typically grow into the brain as opposed to throughout the brain. So the tumor actually starts on the lining on the surface of the brain and then pushes into the surface of the brain, as opposed to sort of weeding its way into the tissue itself of the brain. That's great news because it means you can literally peel that tumor off the brain and the brain tissue itself hasn't been affected. Meningiomas can cause swelling, they can cause headaches, they can cause seizures. So there are many reasons why you would want to take out a meningioma as opposed to just treating it with radiation. Surgery is definitely a good option for meningiomas. Again, without diving into the weeds too much, if you do end up having a meningioma, and by the way, that's one of the few tumors that can be pretty accurately diagnosed with just an MRI and not having to take a piece of it with a biopsy. But if that is your case, definitely talk to your neurosurgeon. Why is this tumor good for taking out with surgery versus some other method of treating it? There are lots of other types of brain tumors that come from other parts of the brain. For example, pituitary tumors, which obviously come from the pituitary gland. They can cause problems because the tumor cells themselves secrete hormones, and that messes up whatever that hormone controls. And pituitary tumors can also be what are called non-secreting pituitary tumors, which means they grow in size, but they don't create hormones. And they cause trouble by pushing on things in the pituitary. You have to be careful with these tumors because the pituitary gland is near important structures like the optic nerves and the carotid arteries inside the brain. So that will affect decisions regarding surgery. There are lots of other tumors like acoustic neuromas, which are usually benign tumors that affect the nerve that goes from the brainstem out to the ear. There are schwannomas, there are oligodendrogliomas, medulloblastomas. There are quite a few brain tumors, especially the last two that I mentioned, that can be more common in children than in adults. And that brings up a whole different algorithm of how you treat these tumors. when they happen in children. And then there are other tumors that are a little more unusual and diffuse, things like lymphoma, tumors that spread from the spinal fluid. You technically could consider these metastatic tumors, and they're much more rare, but they do exist. So we've talked about what a brain tumor is, the broad categories of brain tumors, the symptoms they can cause. So before we get into sort of ways to think about your next steps, let's take a look at some pictures. And I'm going to use both diagrams and imaging like MRIs to talk about examples of some of these types of tumors, examples of the effects on normal brain that these tumors can have, maybe some before and after pictures, before and after surgery for these tumors. I'll throw in some diagrams about some of the machines that are used for the radiation treatment. And then we'll get into those ideas about what to think of about the next steps. So let's take a look at some pictures. So this screen is really just to give you a sense of structures in the brain, locations in the brain, and the functions that are associated with them. So if a tumor is located in a particular area of the brain that has a particular function, it can obviously affect that function. So for example, on this picture on the left, we can see the frontal lobe here, fairly well developed in humans compared to other primates. And tumors in this location can affect any of these aspects of cognitive function. The temporal lobe here on the side has areas that do with hearing, as well as in this back corner, some areas of understanding speech. This part of the frontal lobe along this edge here deals with motor function of the opposite side of the body, so face, arm, and leg. And then this area of the brain in the parietal lobe has to do with sensation. And then back here in the occipital lobe is vision. And then if you look over on the right, you can see this diagram kind of separates them into categories of function. Hearing, speech, this is speaking speech, this is understanding speech over here. Concentration, attention, memory, movement of the face, arm, and leg on the opposite side of the body, sensation of the face, arm, and leg, opposite side of the body. Back here is vision. It doesn't say here, but the cerebellum deals with movement coordination. So this gives a general idea of what kind of symptoms a patient could get if they have tumor or swelling or bleeding in a tumor that affects normal brain tissue and their function in these locations. This picture of the brain shows various areas that tumors are likely to be. The glioblastoma or GBM or glioma, which technically the astrocytoma can be thought of also, can really occur anywhere in the brain tissue. We're going to look at some pictures later of what's called a classic butterfly glioma, and that's because it crosses the midline of the brain, and that's why they have an example here of a glioblastoma. But really, a glioma can occur anywhere in the brain. Here's an example of a meningioma. As I mentioned, one of the benign, usually benign type tumors, and you can see this is on the surface of the brain, not inside of it. Pineocytoma comes off of the pineal gland, which is located right here. The pituitary gland is here. You can see pituitary adenomas or pituitary tumors, craniopharyngiomas in this area. Brainstem tumors coming off the cranial nerves, like the schwannoma I mentioned earlier that comes from the nerve that goes out to the ear. Various types of tumors in the cerebellum. But again, general ideas of different types of tumors are more likely going to be in particular types of areas. So if a patient shows up in a doctor's office or the emergency room with headaches, maybe a history of some type of cancer in another part of the body, like the lung or the breast, they're probably going to start with a CAT scan. Now, a CAT scan is not going to give you as much information as an MRI, but here's an example of what a CAT scan would look like if they did it in the ER, for example. Usually they will do a CAT scan without IV contrast. And this picture on the left is an example of a CAT scan of the brain where there is a brain tumor in there, but without contrast. This circle here is a suggestion that this is the brain tumor. All of this dark stuff in the brain tissue is edema or swelling, or basically a buildup of fluid. So if a patient comes in with a headache, whether they have a cancer somewhere else in the body or not, the radiologist would look at this CAT scan and say, this is highly suspicious for a brain tumor. There's a circular type lesion here surrounded by swelling. We think this is a tumor. They'll either then send you directly for an MRI, or they may, while you're in the CAT scanner, give you contrast through the IV. This picture on the right is an example of the same CAT scan with contrast. And here you can see the tumor lights up. It's a bright ring around the center, around the outside of the tumor. The center is dark, which could indicate that the tumor cells have kind of outgrown their blood supply inside the tumor and they've all died off. And only the outside ring is live tumor cells. All the swelling does not enhance with the contrast. That'll stay dark. There is some brightness over here. This could suggest uh, more tumor. This could also be a blood vessel, but likely more tumor. So this picture on the right, as I said, is the CAT scan with contrast. The one on the left is without. And this might sometimes be the first scan that somebody gets when they're first diagnosed with a brain tumor. So as I said, after the CAT scan shows evidence of a brain tumor, the patient will likely get an MRI. Here's an example of an MRI of the brain where the MRI is done in different sequences. This one on the left, as it says underneath, this is a T1 sequence without IV contrast. And here you can see evidence of swelling in the brain. You can't really see the tumor. In hindsight, you could possibly say it's right there, but you're not going to really be able to see the tumor without the contrast. But on T1 images, swelling or fluid is dark. And you can see this abnormal darkness, which looks different than the other side on the right side of the picture here. There's another sequence of the MRI called the flare image, which will show fluid from tumor swelling light up like this. And here you can see all that edema or fluid around the tumor. The picture on the right is the same picture as on the left here, but with the IV contrast. So again, around the tumor, you can see all the swelling, the darkness on T1, which is fluid, but the IV contrast that's given while you're in the MRI machine, the tumor will light up like this. So this is a very definitive picture of where the tumor is and what it looks like. It doesn't look like there's tumor anywhere else, at least that you can see grossly or on a large picture like this. But this is a very well-defined tumor. This could be a glioblastoma or it could be a metastatic lesion. But this is an MRI showing T1 with and without contrast, the tumor and the swelling around it. So these pictures are MRI images of patients with glioblastomas. These are two different patients. Here is a large brain tumor on the left side of the picture in the frontal lobes, surrounding swelling, pressure effect, pushing the midline of the brain here. Dark spots inside the tumor, or what you could call this is a heterogeneous or different colors inside the tumor itself, which suggests that the tumor tissue inside here may be, as I said before, starving out its blood supply and dying off. But this is with contrast, showing bright enhancement. This is a hemispheric tumor. Technically, this could also be a metastatic lesion, but the source of this image confirms that this is a glioblastoma. And here is another picture of a glioblastoma in the classic butterfly configuration, where it has crossed the midline through the corpus callosum. The corpus callosum is this band of tissue crossing from one side to the other in the brain. The enhancement around the outside edges is called ring enhancement. And again, it suggests the inside of the tumor is necrotic or dying off. And this is, again, fairly what we call pathognomonic for glioblastoma, this crossing the midline with a butterfly shape configuration on imaging. Glioblastoma, hemispheric butterfly. Here is another MRI T1 sequence with contrast, and this is an example of metastatic disease. Again, this could be lung cancer, could be breast cancer, could be melanoma, renal cancer. But the issue here is we see more than one lesion. Here's a tumor on one side of the brain, here's a tumor on the other. Again, this is probably a little higher up image. You can see both tumors left and right. This is highly likely or indicative of metastatic disease from another location in the body. So here we have an MRI of the brain, T1 sequence with contrast showing a classic meningioma. What is really notable about this tumor on this image is number one, it's a fairly large tumor, but look, there does not appear to be a lot of mass effect or shifting of the brain tissue. That suggests that this has grown very, very slowly, could be over 10 years, 20 years, and the brain has accommodated to that. The patient may not have had any symptoms even, and this was found incidentally. The other thing to note is that the inside of the tumor is fairly homogeneous, which means that the signal on the MRI is fairly equivalent. There are some lower intensity areas here compared to here, but overall, compared to the metastatic lesions or glioma lesions that we saw in the other images, this is fairly bright white throughout. And then finally, the other big pathognomonic indicator that can tell you this is a meningioma just from looking at the MRI without doing a biopsy is something called the dural tail. That is this little sliver of enhancement that follows the dura, which is the covering of the brain, out to each side, here and here. So homogeneous enhancement, not a lot of mass effect given how big it is, and dural tails on the image, we can be very, very confident this is a slow-growing meningioma and likely benign and not malignant. This tumor could technically be cured. You remove the dura from here and here past the edges of where it enhances, peel this tumor off the brain. Hopefully will come out in one piece, like a big golf ball, or this maybe the size of a lime. All in one piece. You can kind of shrink this as you operate on it, and it pulls away from the brain. And then over time, this will all re-expand eventually. So this is a classic example of a meningioma, benign, on an MRI of the brain with contrast. And then finally, just for completeness sake, this is also a meningioma. However, this meningioma is acting differently than the previous picture. This is an MRI of the brain, T1 sequence with contrast, and again, homogeneously enhancing round mass, a little bit of a dural tail here, maybe even a little bit here. But what's significantly different here is there's a lot of edema or swelling in the brain. On the FLAIR image, you can see all the swelling here. And this could suggest that the meningioma is transforming into a more malignant version of meningiomas, which are relatively rare, but they do exist. Or it could be fooling you, and it is not a meningioma, it is a glioma or metastatic lesion. But a biopsy during surgery when this is taken out is what's going to be definitive. But again, just to show that even if you think it's a meningioma based on these characteristics, either the meningioma could be malignant because we're seeing all this edema, or maybe it isn't a meningioma or is not a meningioma after all. So now let's take a look at pictures of before and after surgery for brain tumors. Here is a classic meningioma, well enhancing, not a lot of pressure, not a lot of edema, pretty significant dural tail, enhancement of the dura, the membrane covering the brain. After surgery, the tumor is pretty much gone. I do see some enhancement in the dura here that matches the location of the dural tail here. This could mean that the meningioma has a higher chance of coming back or growing back because of this enhancement in the dura. If this were my patient, rather than reoperating just to remove this small piece, I would follow this patient maybe with an MRI once a year to see if anything starts to grow off of this. If it does, options could include radiation, focal stereotactic radiosurgery just on this part of the dura to kill off any tumor cells that might be living there, to prevent it from regrowing if we start to see some growth. Um, or if it did grow back significantly and the patient did not want radiosurgery, it would be very easy to go back in with a relatively superficial surgery and just remove this piece of dura. But this is a pretty good result for removing this tumor, and this could effectively be thought of as a cure, assuming nothing regrows from this little area here over the first 2 or 3 years. So again, meningioma, uh, primary benign brain tumor before and after surgery. Here's an example of before and after surgery for a malignant brain tumor. This could either be a glioma, glioblastoma, or a metastatic lesion. Um, there does not appear to be a lot of edema around this, but regardless, this is the tumor before surgery, and here you can see it's pretty much completely gone after the surgery. Um, uh, Keep in mind, if you get an MRI immediately after surgery, or I would say in the first 2 to 4 weeks after surgery, you may see some enhancement around the edges of the surgery bed, the surgery area where you took out the tumor, just from inflammation from the surgery itself. So, what I will typically do is get a CAT scan the day after surgery or the next morning after surgery to make sure there's nothing bad going on in here, like bleeding or anything like that. And then, if that looks good, I will not get an MRI of the brain with and without contrast for probably 6 weeks after the surgery. By then, all the swelling or irritation from the surgery has calmed down. And if you see enhancement in this area, it is more likely a tumor that was left behind from the surgery as opposed to swelling or irritation from the surgery itself. So I'm not sure when this uh, after surgery MRI was taken, but this is a very good result. I wouldn't be surprised if this is maybe some material that was left in to stop bleeding or line the bed of the resection area after the surgery as opposed to actual tumor regrowth. But this is a metastatic looking tumor before and after surgery on an MRI. So, on a final note, with respect to some of these pictures, let's take a little look at what radiation therapy is all about, because that is a big part of treatment for brain tumors. Conceptually, we can think of traditional radiation therapy where you kind of give a concentrated amount of energy to an area near the tumor. You can see that this is not very exact, even though there's a high amount of radiation therapy given to the tumor area. Other parts of the brain receive doses of radiation that don't look very well controlled. But this was the mainstay of treatment before stereotactic radiosurgery came about. That's over here on the right. But before we look at that, whole brain radiation therapy, which would be important for metastatic tumors or gliomas, because we can assume that there is microscopic tumor cells throughout the brain, not just in the spot that you can see on the MRI. And here you can see with whole brain radiation therapy, the entire brain gets radiation therapy, hopefully killing off tumor cells that are dividing, but not bothering cells that aren't dividing, like brain cells. There is a boost given to the tumor area, but the entire brain gets radiation. In more modern times, we now have stereotactic radiosurgery, where you can localize the beam of radiation to a finite area, sparing the rest of the brain. So this is kind of a good image of the general concept of uh, stereotactic radiation therapy, focal radiation therapy, and whole brain radiation therapy. Now let's take a look at some of the different types of stereotactic radiosurgery. So I know this is a busy slide, but when we're talking about different types of radiation therapy, the very first stereotactic radiation therapy was called the gamma knife, and this is up here on the left. And we can see in real life, it's this big silver colored helmet that the patient's head is slid into, and it has all these holes in them that can be covered. And if the holes are covered, the radiation can't get through the holes. And if they aren't covered, the radiation can get through the holes. And based on the target of the tumor, the computer will tell you which holes to leave uncovered in order to get the beams of radiation to kind of summate at the point of target. So here you can see all these individual beams of radiation that by themselves are not necessarily harmful to tissues, but where they all meet at a focal point, they have enough energy to destroy the tissue. And this was the original stereotactic radiation treatment method for brain tumors. That evolved and now includes things like for example, the cyberknife. And keep in mind, there are many different companies and variations on these themes. But instead of a stationary helmet and stationary radiation source, there is a movable radiation source. And the radiation beams can be tailored to their focal point where the tumor is based on movement of the radiation source in the arm, as well as collimators that are inside this arm. And here you can see down on the bottom left where they kind of describe the differences that these forms of technologies have in delivering the radiation therapy. So the gamma knife on the left, cyberknife on the right, more limitations in angles of treatment, and also how much energy is delivered at one time. So these are differences between the two. And then another example of a type of radiation therapy is proton beam therapy, using a different radiation source. And the big takeaway from proton beam therapy compared to usual radiation therapy is the claim that the energy is delivered to the tumor and none of that energy passes through the tumor to bother tissues down here in this example. So again, stereotactic radiation therapy like the gamma knife and the cyber knife here versus the newer proton beam therapy here. There are some arguments that for example, traditional radiation therapy versus proton beam therapy might be better with the traditional radiation therapy because of the ability to deliver higher energy and lower the number of sessions that you need with regular stereotactic radiation therapy versus proton beam therapy. So this is kind of a summary slide of various aspects of different radiation therapy treatments. The topic is so detailed that what I'd really recommend is when you meet with your radiation oncologist, you have a detailed discussion about why what they are recommending is perfect or ideal for your type of tumor. And then the last thing to mention is that with recent modern advances in immunotherapy, radiation therapy may not even be necessary at some point in the near or maybe not too distant future, where we can get molecular markers of your specific tumor and then tailor make a immunotherapy that basically hijacks your own immune system to go and find the tumor cells and destroy them while leaving all the other cells intact without harm. And in my opinion, that is really the future of cancer therapy. And there have been tremendous strides made in the last decade in that type of technology. So that would be something to talk to your oncologist about with regard to immunotherapy. So I think that's enough of pictures for now. Let's get back to the video on general concepts about brain tumors and sort of how you should think about things at this point. So a quick word about brain tumor surgery. The good news is brain tissue itself does not have any pain fibers in them. So brain surgery for brain tumors is typically not very painful. If the brain tumor is in the back part of the brain and you have to go through the back of the neck muscles, there may be some muscular pain for a few days, but overall the level of pain from a craniotomy, which is a surgery to open a section of the skull, is not very painful. Usually you'll spend the first night after brain surgery in the intensive care unit, and that is most likely to keep an eye on you, so to speak, and your neurological status to make sure you're not having any complications after a surgery, the number one of which would be bleeding in the area of the brain tumor. The most likely period of time for that to happen is in the first 24 hours after the surgery. So usually you'll spend the first night in the intensive care unit and you're not going to get a lot of sleep. The nurses are going to come in every hour and ask you, what year is it? What's your address? Show me 2 fingers, wiggle your toes, that kind of stuff, to kind of check the boxes that your brain is functioning properly. You'll be given medicine for nausea, maybe medicine for seizures. Operating on the brain can irritate the brain tissue and increase the chance of seizures. They'll want you in a sort of a quiet, dark place with not a lot of stimulation. They don't want your blood pressure going up. No talking about taxes or politics or anything like that. You're not going to want to get riled up that first night. So they may limit the number of visitors that you have. Usually the next morning, the neurosurgeon will get you a CAT scan, make sure the area where the surgery was looks good, no excessive bleeding. You may even get an MRI in a couple weeks to see how much of the tumor was taken out. Keep in mind you can't get an MRI right away after surgery because irritation from the surgery itself can fool you into thinking that area is tumor when it is simply just post-surgical irritation. Usually after the day after the surgery, you'll leave the intensive care unit as soon as you can eat something and walk, go up to a regular room. They may watch you in a regular room for 1 or 2 days, and then you'll get to go home. You'll probably be given instructions to lay low for about a week or 2. No driving, no housework, no yard work, no walking the dog, no taking the trash out, no exercise, no going to work. And then in a week or 2, you'll be back to see your neurosurgeon. Your stitches or staples will come out of your incision. They'll check your incision. They'll look at any scans you've had. They'll check your neurological exam. By then, the results of the pathology during the surgery will have come back, and you will probably be given referrals to whatever type of oncology doctor you're going to need after the surgery based on what type of tumor it is. And that's kind of an abridged version of what you'd go through for that brain tumor surgery. If the surgery is near an area of important brain tissue, parts of the brain that control speech or movement or vision or things like that, they're going to pay special close attention to those neurological functions after the surgery to make sure that they still are intact. If you have a deficit in one of those areas, speech, movement, vision, etc., you may be on some steroids after the surgery for a week or 2 to cut down on any swelling or irritation from the surgery itself. And it is possible some of those functions could come back if it's simply just irritation to normal brain from the surgery itself. Keep in mind, however, there are risks to this surgery. 3 of those risks are the same for any kind of surgery. It doesn't matter what kind of surgery it is. And those are infection, bleeding, and problems with anesthesia. All relatively low, but they're in the books, so we have to tell you about them. And that's why before the surgery, if there's time, they'll get chest x-rays, EKGs, blood tests, make sure you're as healthy as you can be. The special risks to the surgery, because it's near the brain, are basically injury to those important structures. Speech problems, movement problems, vision problems, all based on what part of the brain the tumor was in and whether the surgeon was able to be aggressive or not in taking out that tumor. The more the surgeon is aggressive and wants so-called clear margins around the tumor, means the more normal looking or appearing brain he's going to have to go into to remove in order to get a margin of brain tissue that has no tumor in it. So the more aggressive the surgeon attempts to be, the higher the chance of a neurological problem if the area the neurosurgeon is operating on is near an important area of the brain. So that's kind of a short, abridged version of what it's like to go through that surgery. So we've gone over basic concepts about brain tumors. One of the things I wanted to touch on are what do you do, let's say, if you have a malignant brain tumor or some type of rare tumor that's hard to treat, and you've gone through surgery, you've gone through chemotherapy, you've gone through radiation, and the tumor is not going away or it keeps coming back. One of the things that you may be talked to about by either your oncologist or your neurosurgeon are clinical trials. These are basically experiments on treatments for these tumors. And one of the concepts I want you to understand is that everything that you've already gone through is what's considered the standard of care. And the standard of care you can probably get anywhere across the country for that particular type of brain tumor. But the thing to keep in mind is that the reason it is the standard of care is because it used to be a clinical trial, the results of which were found to be better than the standard of care that was going on at the time of the clinical trial. So our current best treatments for these brain tumors weren't always the best treatments, but they were discovered to be the best treatment through a clinical trial. And once that clinical trial shows that, oh, this new treatment or this different way of treating this type of brain tumor is better than the old way, then everybody now treats it the new way, and that is now the new standard of care. So let's say you're unfortunately one of those patients where you've gone through all the current standard of care treatments and the tumor's still there or it keeps coming back. And you're thinking of trying a clinical trial. Well, just remember, that clinical trial is really potluck. It's really a long shot. It's like a Hail Mary pass into the end zone in the last 5 minutes or 1 minute of a football game. It's possible that the treatment that the group that's doing your clinical trial is trying for your brain tumor is not better than the standard of care, or doesn't work really at all or very well, or has terrible side effects. And unfortunately, from a statistical standpoint, most of them are not better than the standard of care. But keep in mind, remember, your standard of care was a clinical trial that turned out to be better. So it is possible that the clinical trial that you happen to pick could be that one special clinical trial that turns out to have better results than the current standard of care. So the lesson learned here, or the thing to take away from this is you don't give up, you keep trying, and if all the current treatments aren't working, it is definitely not unreasonable to consider a clinical trial. And it's worth the chance that you could be one of those lucky patients that happen to pick a clinical trial that all of a sudden makes that tumor shrink up or disappear when the current treatments weren't doing that. So my advice with the clinical trials is talk to your oncologists, talk to your neurosurgeons, and get their advice on what clinical trial that's currently going on in the country or out of the country that has the best chance of possibly beating the current standard of care. So I just wanted to mention that about clinical trials. So finally, I want to sort of end this video with a little bit of a talk about living with a brain tumor. Living with a brain tumor is not easy. There are certainly many challenges, but I can tell you that while I've been a neurosurgeon, 30 something years, I've seen dramatic changes in how we treat brain tumors and how long patients can live with brain tumors. So if we just make the assumption that you're going to live a long time with this brain tumor, there's some important things to remember about while you're doing this living. And that is, number one, communication. It is really, really important that you communicate with your medical caregivers. Oncologists, surgeons, primary care doctors, radiation physicians. Don't hesitate to talk about how you're feeling, your symptoms, changes that you've noticed, side effects of things. Don't hide them. Don't forget about them. Don't brush them off. Communicate. So that is going to ensure that you have the most optimal outcome and least side effects of your medications and treatments. The second thing is always keep in mind and think of that weighing scale that has quality of life on one side of the scale. It's great and wonderful, and I encourage the good fight against brain tumors. But always keep in mind how important quality of life is. So if the fight that you're fighting is starting to kind of cut into the quality of life that you want to live, you have to really think about the balance between the two. And you may opt for a better quality of life and less treatment. So that is not necessarily the wrong thing to decide, but it's a personal thing to decide. So that is something that you have to take into account: your beliefs, your physical feeling, and side effects from treatments, what kind of family support you have, what kind of lifestyle support you have with being able to live independently. So just keep in mind, quality of life is very important when you're making decisions, and always factor that into your decision making. In addition, I would recommend not thinking about second opinions as a bad thing. Second opinions are normal, second opinions are valuable, and if your physician is a good physician and is confident, they should not be bothered by a second opinion. Second opinions can make you feel better by knowing that what you're already doing is the right track. Second opinions can also be great if the second opinion comes up with something, thinks about something, or has experience with something that your current medical team doesn't, and it opens up a new possibility or opportunity for you during your treatment. So I would highly recommend second opinions, and they can be, regular second opinions over time. They can be second opinions only when something new turns up about a treatment or a problem. So don't hesitate to get second opinions, and think of them as a normal part of your treatment process. Lastly, I can't emphasize how much emotional support is valuable in the ultimate outcomes of treatments for brain tumors. If you are psychologically and mentally and spiritually doing well, the treatments tend to work better. I don't have a great scientific basis for that, but supportive family, surrounding yourself with supportive friends, neuropsychologists, social workers, mental health counselors, yoga, exercise, travel, anything and everything that improves your mental health status and your positiveness about what you're going through in the world around you tends to make treatment outcomes better, or side effects less or more tolerable. So I would definitely not underestimate the value of putting time, energy, and effort into the emotional side of your well-being, understanding that it has a link to the physical side of your well-being. So I think that's probably enough on a general video on brain tumors. Like I said, this is a very complex topic, and each type of brain tumor could be an entire couple of hours of video. I may make individual videos on maybe the top 3 or 4 most common brain tumors and dive deep into treatments and genetic markers and imaging characteristics and particular parts of the brain that are affected, and really dive deep into that particular type of brain tumor. But for this particular topic, we're just doing a general overview. I hope that was helpful. I hope it kind of helps organize things in your mind about what's going on with the concept of a brain tumor, and the fact that you or your loved one has that doesn't mean there aren't options. So again, I hope it was helpful. If it was, don't forget, like, subscribe, share, thumbs up, all that kind of stuff. I appreciate you listening, and I'm glad I could play a part in your journey. And don't forget, most importantly, stay healthy.